have become a strong family of almost 500 people every webinar. Even today, we have about 400 people registered on this webinar. So, before we launch any further, let me introduce myself. I'm Dr. Mohit Venkataram. I'm an executive director at East London. And I have, for the last 20 years or so, had experience of working, managing, and supporting primary care in leadership positions. Our maturity as a system is in recognizing that the best care can only be delivered to our residents when the care is closest to them and the care provided is resilient. And this is done in primary and community care services on a regular basis. It is for large organizations in each footprint, like organizations at North East London and East London, who are committed to ensuring that the vast corporate resources that we hold are shared with our primary care colleagues, recognizing that by supporting them, we are supporting good clinical care. Now, over the last few years, I am sure many of you have read the fact that we have been challenged in many ICS across the country to be able to get GP appointments. Figures like 1 in 5, 1 in 7, 1 in 2 have been quoted for different ICS on a regular basis. While none of us sitting here today can agree it is right for patients to wait, no patient should ever have to wait to access health services. The issue, though, is that the story that's quoted is only part of the picture. The fact is that in February 2024, primary care delivered 30 million appointments in 1 month. In February 2023, primary care delivered approximately 27 million appointments. That is 3 million more appointments, more than 10% increase from the 27 million base in 2023. 90% of these appointments were attended, and about 2/3 of the appointments, at 66.66%, were face-to-face appointments. It's astronomical, actually, that one part of the health sector, which receives the least amount of resources compared to the rest of the health sector, is able to deliver such large-scale transformation and change. So clearly, the answer can't lie in the resource alone. Because if resource alone was the answer, then larger sectors, which were getting larger shares of the NHS resource, should have been able to do better. So the work in primary care workforce transformation, the work in primary care behaviors and leadership is what makes all the difference. Traditionally, many of you will recall from days when we were young to days when we have started taking our children and grandchildren to the GP surgeries, we've always been used to seeing a GP and a nurse in the surgery. But the reality is, even if primary care was given endless amount of resource to get as many GPs that are needed, we do not have enough GPs in the country to make sure all the appointments were delivered by a GP alone. So, there are national leaders who are making strides in changing how workforce delivery happens in primary care. And one such amazing leader is Dr. Neil Modha. His immense experience in primary care leadership, both clinically and managerially, in his variety of roles, like the clinical director of Thistlemore Primary Care Network, chair for the Greater Peterborough GP Federation, and co-chair for the North Place-Based Board in various facets of his leadership role, have been instrumental in creating a phenomenally different workforce response in primary care. His pioneering approach was also quoted in the National Primary Care Stocktake, which is where I was introduced to Dr. Modha for the first time. I am immensely pleased to be able to welcome Dr. Modha to today's webinar. But before I hand over to Neil, may I remind colleagues, we are being streamed live on a number of platforms. There are more than 400 people who have registered for today's webinar. If you have any questions, please post your questions on the Q&A section. For those colleagues who have already sent their questions through, I will be picking them up. We will be using themes from the questions that are sent to us so that Dr. Modha can share his thoughts. Without further ado, let me have the pleasure of welcoming Neil. Neil, welcome to the webinar.
Oh, thank you. What a great introduction. Thank you.
Can I hand over to you to share your thoughts on the fabulous work you have been doing that's been quoted nationally on the primary care workforce? And then perhaps we would open it up for some questions. Does that work for you?
Yeah, that is perfect. Now, my first disclaimer is that in the background, my wife is at I think, medical educators forum. And so I've got two girls, okay, aged 5 and 9, and the 9-year-old is putting the 5-year-old to bed. Okay, so this has not been trialed before. It's an innovative way of managing children. But if children come in at some stage, I can only apologize at this stage. But let's try our best. And if I look over my right shoulder, just ignore me. Okay, but yeah, so hello everyone. I'm Dr. Neil Modha. I'm a GP by background. And yeah, I've prepared kind of some slides, I guess, taking you all through the story of where we came from, where we are now, and I guess where we imminently want to go. I always kind of think that people will sometimes quote me as being an expert in primary care, an expert in general practice. I guess I've got lots of lived experience in transforming general practice or changing how things work. But I think that I'm very much an expert on my area, in my area. I think if you lift and shift me into London, if you put me in Newcastle, I don't know, I wouldn't know that area well enough to make judgments there. So I guess what I'm talking about is the experience that I've got and kind of how I've made some of the decisions that I have. So I'm just going to share my screen. So bear with me 1 second. There we go. I think you should be able to see this now. So that should be in the big screen. So our approaches to general practice by myself, Neil Modha. So I guess I'm one of those stories of a child of immigrants. So my parents were, kind of under the they left Uganda under the influence of Idi Amin, and I always say that he was one of those dictators that in some way was fair. He said, get out or we will kill you. The people who didn't get out, he was sadly true to his word and made it very, very difficult for them. But many people then came as migrants to the UK, including my parents. And my parents sort of left with £50 to their name, but medical degrees. And my parents both tried to work in hospital jobs. My dad would have been an eminent surgeon, but I think he realized at that point in Britain, number of factors, I guess, racism, struggles, challenges, etc., that actually general practice was a really good pathway. And part of that was that, with the general practice model, it allowed you to be a GP once you qualified, and you could then, there were little boundaries on your career. You could do what you wanted. And one of those kind of things that he did was he became a partner in a very successful Peterborough practice. My mum, who is, I guess, the real stalwart of the Thistlemore story, she was a GP that worked in a kind of inner city deprived practice. She was the equivalent of, I guess, a salary doctor. She wasn't kind of, she had an interest in helping kind of police cases. And so she was the only female Asian police surgeon in kind of Cambridgeshire. And with that, she faced a lot of challenge because she was, I guess, a salary doctor having to go out to rape cases, child abuse cases, and things like that. It rubbed against, I guess, the partnership model that was there. So one day when she had to go and testify in court, the senior partner said, "You can't do that. We need you to run the surgery." And she said, "Well, I'm sorry, it's a very important case." She stormed out of the surgery, resigned on the spot, and without much plans, to do much further. That was in 1994. And at that stage, next to that surgery, there was you can see the picture in the top left-hand corner, a single terraced house on the right-hand side of those three terraces. Thistlemore Road was a very long-standing GP surgery. It cared for only 700 patients. That white garage door had wine behind it, so the senior partner there was brewing wine in his garage. It wasn't posh enough to be a 2-up, 2-down. It was a 1-up, 1-down, and there was only one clinical consulting room. The staircase was the waiting room. So that was the good old days before CQC and things like that. My mum took over that practice against all odds. The PCG, I think at the time, the primary care group wanted to close it down. It was a condemned building. And I guess a theme of this has been a desire to show people what's possible, that actually, we want to take on this decrepit, facility that has got no kind of means and no ends of really providing high quality primary care. We're going to kind of invest our own personal money. So they mortgaged their houses. They did that to improve the facilities. And my mum started that journey in 1994. Over the course of 1994 to 2008, I think those were the most tricky years. To take that practice from 700 patients in a condemned building to 8,000, which is really my parents' story, that was an amazing journey. That was against prejudice. That was against lots and lots of struggles. And at part of that time, I always think Peterborough is a bit like a volcanic surface. So lots of innovation comes from Peterborough, but I think it's because things are really difficult in Peterborough. This kind of current situation with a lack of workforce has been in Peterborough since that time. And so in 2008, when I joined, there were 8,000 patients. There were about 30 staff, 4 doctors, 2 of which were my parents, and one sort of retired kind of doctor who came back to support them and myself. So that was how the practice started when I took it on. It wasn't a training practice, but it had lots of nurses. We had a good number of nurses and a good number of HCAs. I guess fast forward to today, the practice now has 31,000 patients, about 120 staff. Still quite low on partners. I think one of the partners might be on the call, Karen Hamilton, but it's still quite low generally on partner numbers compared to most traditional GP surgeries. It's got a number of nurses, including pediatric nurses, paramedics, pharmacists, health and wellbeing coaches, social prescriber. Gina, I think, is on this chat as well, who's one of ours. And I guess the journey that my parents took was to explore workforce. And I guess what they found is that at their time, it wasn't like it is now. So now for general practice, we have a budget in which we can run our general practice. In their day, they had to grow the list to recruit more doctors. So actually, if there were 4,999 patients, you were not allowed to recruit another doctor. As soon as you hit 5,000, that's the trigger at which you could then recruit another doctor. And so part of the kind of pressures on workforce were, if you weren't even allowed to recruit a doctor, because actually, or you've got, it's not about your budget, it's about your list size, you had to find ways of innovatively solving these problems. And one of the kind of gifts that they had, I guess, is that, in some way, I'm a very sad family. My mum's side especially is very sad. They're all doctors, married to doctors. The dog's a doctor, the cat's a doctor, the postman's a doctor, everyone's a doctor. It's a very sad story. And my mum's side of the family are all in America. And I guess one thing that we saw was that a lot, when we went over to America, a lot of the healthcare wasn't delivered by doctors. It was delivered by healthcare assistants, I guess physicians associates, GP assistants, and things like that. And I guess what we wondered was, in the most litigious country by reputation in the world, if you can have a model that involves the doctor as the decision maker and then lots of other people in the team, why can't we do that in the UK? You know, and so actually at that time, it was in the sort of 90s, my parents went over to America, saw the models that they had there, brought those techs over to the UK, personalized them to the NHS, personalized them to general practice, and basically recruited local workforce that had never worked in the NHS and trained them up to be the healthcare assistants of the future. At that time, there were no healthcare assistants hardly any in the NHS and hardly any and none in general practice. So they actually introduced healthcare assistants to general practice. And obviously, what they were trying to experiment with at that time was where could another person add value to a consultation that a GP didn't need to do. And I guess that master art of delegation, or the GP being used at the top of their skill set. The other thing that they were very keen on experimenting was, again, when they compared America and the UK, they saw that nurses in America were doing all sorts of things. And at that time in the UK, nurses sometimes were even frowned upon doing a blood pressure. And so actually what they wanted to do was push the boundaries, train, develop, and increase kind of the ability of the nursing workforce to do more chronic disease, long-term condition, home visits, and things like that. And again, now, I guess most of us on this webinar would say, well, that's just common general practice. But at that time, it was highly controversial. They were threatened with reports to the GMC and all sorts of things. So, but really, that story is my parents' story. As I joined in 2008, I guess what I saw was, again, the need to think big, to think at scale. And you know, I say that we were very lucky. We had chief execs, obviously nicer than Mohit, I'm sure, but would come into the Thistlemore surgery and say, you're not big enough. 8,000, you're not big enough. 10,000, you're not big enough. 15,000, no, that's not sustainable. So in our DNA, I guess you've got a story of migrants who've been pushed out of a country. You've got this fuel of growth, people saying actually growth is important. And so what do? We embrace that agenda. We're like, well, okay, we're going to grow. And how do we grow? Not in the kind of corporate way of buying surgeries, selling surgeries, taking over surgeries. We wanted to focus on patient care. What was the key thing for patient care? Access. So we wanted to provide as much access to the population as possible, because that would allow us to provide a good service that would attract patients to our service and would allow us to grow. And in that way, that's the theme of which we've used to grow the surgery. And, you know, I'm very proud to say in my, I guess, 15 years or so in the practice, 8,000 to 31,000 patients by following that methodology. I guess as I came into the practice, I had an interest in healthcare management, and that took me away into some kind of PCTs and running a CCG and all that kind of stuff. Those were my side hustles, if I'm quite honest. But my core was always kind of thinking about the general practice and thinking about actually the stuff that I was talking about in those forums. How do we make them real in general practice? And so one of the things that I observed as I came in was that nurses were doing consultations then supported by doctors. And I guess the thought that I had was actually, why don't we utilize the healthcare assistants to gather information? We don't throw a healthcare assistant on the bus and say, well, you've not taken a good history, you missed a red flag, because they're just a healthcare assistant, just like you might use an engage consult or e-consult form. It's just a form. You can't blame the form for not gathering data correctly. So we started to utilize the healthcare assistants to gather information. And then I guess a beautiful sweet spot, whenever Peterborough is on the news, it tends to be about migration. And one thing that we found was that in the workforce, there were people that were lawyers, that were all sorts of professionals, economists in their own countries, who were working in fields, factories, and farms in our local community. And so when we saw that kind of people's CVs coming to our door, okay, they'd never worked in the NHS, okay, they didn't speak English to the best ability, but what they could do is communicate with our patient population really well. And so what happened is, because we trained people up from the local community, they could actually then converse and talk to our patients. And so our patients found that a really good resource in terms of communication, but not only the verbal communication, but cultural communication. the NHS doesn't work like this. Actually, I know in Poland that you can do things like that, but actually, this is how the NHS works. Now, coming from a brown doctor with a very little bit of Polish, I'm not sure how well that lands, but coming from someone from their own community, it lands really well. We were seeing patients being seen in the GP surgery, going to A&E, going to the walk-in centres and things like that. As soon as we enhanced communication, we saw a lot of that stopped, and we went from one of the highest offenders, I guess, with patients going to ED to one of the lower ones, despite our proximity to the ED department. So I will talk to you a few more about some individuals in our staffing team, because Mohit was keen that we think about workforce and things like that. But as you look at my list today, I guess the bit that was probably different to most practices, GP practices, would be the number of healthcare assistants. So we continue to actively recruit people from the local community, train them up to augment healthcare, to communicate. And from a doctor point of view, what they do for us is they do like our blood test reforms. They handle a lot of the QOF stuff. They book them in for chronic disease clinics. They arrange the blood tests. They print off the forms. They document stuff in consultations. Again, not throwing them under the bus. I will take responsibility of my consultations, but they help us. They're our assistants. That's how we utilize that workforce. I guess the other thing, later on we could explore further. So, obviously I was very happy to be part of the Fuller Stocktake. I know there are critics of the Fuller Stocktake, but I kind of believe in the vision, which is that actually general practice should be outward facing. General practice should think about its position in the system and think about it, how it works with partners in the system. For a long time, in that picture, the lower picture there is almost the facade. So those terrace houses still exist. They're at the core of our building, because why would we get rid of our history? They're obviously part of our history. They're part of our building, but we've built on every single boundary around it: up, down, left, right, top, backwards, forwards. Everything is built on. And now, if you came to Thistlemore, you would see some lovely glossy buildings like the ones you see on the bottom left-hand side. And part of that glossy building is Graham Young's Chemist. And now Graham Young's pharmacy, very dedicated man, a pharmacist for 30 years, died of pancreatic cancer very suddenly, didn't have any dependents, left the business to the people working in the shop. They went from earning £5 an hour to £20 an hour overnight, and they couldn't run the business. And so what happened is, in the GP surgery, we would prescribe salbutamol, and the pharmacy would say, well, they should have issued Ventolin. There wasn't joint working, between the pharmacy. And so it kind of ran sort of down into the ground. And so there was an opportunity to purchase it. So we purchased it in 2007 alongside our cousin, who was a pharmacist, and she ran the pharmacy. Alongside the pharmacy deal, we had to buy all of the buildings around it. Okay. And all of the buildings around it were £1 million. Okay. The pharmacy itself was about 1.5, and the buildings around it were worth £1 million, inner city deprived Peterborough. At that time, we had about 8,000 patients. Okay. So it was a big risk. I think now when people see the Thistlemore story, they go, it all makes sense. Of course you would do all of those things. But at the time, a lot of it hasn't made sense. It's worked out in the end, but we've taken some strategic risks, some gambles, and hopefully they've paid off. One opportunity then, with all these changes in the world, has been to think about then the integration of pharmacy. So for the, I guess, however many years, about 14 years that we've owned it, we left the pharmacist to run the pharmacy, carry on, just run it. We worked side by side, etc. But now, with the changes in the pharmacy contract, we're exploring really closely what that true integration can mean. So an example of which is Pharmacy First. So the pharmacy, when we took it over, fully took it over, which was about a year ago, that December, it had done 0 consultations. The last December, the one that's just gone, it did over 1,000 consultations. Okay. And so our vision was to move away from selling shampoo and hair grips, because I don't need them, to actually trying to build one of the biggest community clinical pharmacies in the country. That's the vision. Okay. And by that, what we really want to experiment is this kind of thought of what could the primary care family do if it worked closer together. And the pharmacy, as we took it over, had about 15 staff. Now it has 30 staff. And one of the things that we're kind of learning from, when I joined Thistlemore, I really wanted to be a training practice, because I believe the future of the NHS is in the trainees. Okay. All of us at some stage will no longer be working. It's about the next generation. So being a training practice helps me continually recruit. Yeah. And so we touch a lot of wood. We do not have a problem with recruitment, because we recruit our own trainees generally, and our own trainees then some of which have gone on to become partners. So there's a lovely kind of self-fulfilling kind of nature to that. And that's the model that we're doing with the pharmacies. The pharmacy has gone from having 1.5 pharmacists to now having 6 pharmacists who rotate around the general practice. They do practice work, they do pharmacy work, they do consultations, and that all adds value to the patient journey, basically. There's system 1 in the pharmacy, there's system 1 in the practice, and so we can communicate directly backwards and forwards. Because we're fully integrated, we trust each other. And so therefore, if the pharmacist says someone needs to be seen in general practice, we see them. With the beautiful hindsight, we can say, oh, that case didn't need to come, but we trust them enough to take their judgment and say, well, if you need to see us, we are happy to see them. The other thing that's on our site then is an endoscopy unit, and that does upper and lower GI endoscopies. And I was going to say our future plans, but our current plans, we're hopefully just about to get planning permission in the next week to build a 3-story unit that will host hydrotherapy, rehabilitation services. I'd love to put a dentist there, so we're talking to the commissioners about putting a dental unit there, as well as then some hospital facilities. So I think I've spent 20 minutes on that slide. I'm then going to canter through the rest of the slides, Mohit, so we can open it up to a conversation. But here's a picture of my mum. I'll tell you this, my mum doesn't normally look like that. That is my mum at Windsor. I was very proud to accompany her, and she received an MBE for, I guess, pushing the boundaries on general practice. Over the first slide, I think I've talked about a lot of these things, developing healthcare assistants into kind of GP assistants, as people would now call them, utilizing staff to do more. We're always looking at what's the next thing, okay? What's the next thing? Pharmacists, paramedics, let's do that. And let's think about, I always think, let's not think about one person, let's think about teams. The minimum number of people I want in my team of pharmacists or paramedics is 3. I normally want teams of 5 or 6 because that gives me robustness that covers from holiday, sickness, and all those kind of things. Growing your own, I think, is really important, and I've got a couple of kind of case studies of that as well. So Amelia here is someone who joined us, as many do, wanted to volunteer first, didn't even want to be paid, but of course we got to pay, so we did pay. She worked then as a receptionist. She became a healthcare assistant. That ignited her fire to become a nurse. She went off and did nurse training. She came back to be one of our nurses, and now she's the lead alongside Nadia, who's another nurse of our nursing team. And so we really do love growing our own people that kind of understand the journey, understand the culture, and and want to go there. Now, this lady here, Agnieszka, is amazing. Okay, Agnieszka is a lawyer by background. She was working in a factory. She never believed she could work for the NHS. She's been with us for 10 years, starting on that journey, reception, HCA, etc. And now she's our head of outcomes. So what she does is she spends her life on System 1, just looking at where we're not good enough. Often in my roles, people tell me, Neil, your diabetes is not good. And then Agnieszka's job is to make us good. So she basically, like a dog without a bone, just looks at what are the HbA1cs, where are these patients, why have they not come in, how do I access them? And she's often experimenting then with different ways of communication, AccuRx, System 1 Annex, what's the best way that people engage with, and that is her full-time only and most important job. And so that she's a massive advocate for those things. Mohit, it might be, rather than talking about these things now, there are some examples that I could give of some of the kind of current work that we're doing to test out population health management, social prescribing, and things like that have made some massive kind of changes. But maybe I will save time for that, and we can open it up for questions and conversation if you would like. This is a picture of the kind of next step. So this is the building that I would love. So as I said, planning permission, I hope, is in the next 2 weeks, and I hope that building will be built ready for summer 2025, if not winter 2025. So that's the next episode.
How phenomenal. How phenomenal. It's been so inspiring, Neil. I mean, the only doubt in my head is, should we have invited your parents or you for this conversation? Because they're the architect of the journey of the change to primary care. Yeah. But congratulations on what your mother achieved. It is phenomenal. And hats off to your parents for having turned that around from a 700 list size to an 8,000 list size. That is no joke. In the days they battled to get that right. Loads of questions, as you would expect, Neil. I mean, even in our registration, your name was a draw. To get 400 odd people registered for a webinar is no joke. And we have loads of questions. But The joy I have is that I am the host, so I get the pleasure of asking the first question before we shoot off. So I think the challenge I have in primary care often is the funding model is, while it's different from the days when you were not allowed to appoint another GP until you had 5,000 list size, to a day when you can appoint what you want, but this is the money that you get, and you will get £93 per patient, up to £114 a patient, but that's about all you get, however many times the patient comes in an year. So the question, and that's the part that worries me enormously, is when you look at acute care, in intensive care units, you have a prescribed number of nurses and requirement of clinicians. If you look at mental health, most of the Royal Colleges give guidance on the minimum staffing levels, and that sets the theme of what is the minimum funding required to run a unit like that. In general practice, there is absolutely no guidance. Now, don't get me wrong, I think the innovation that has come from that has been brilliant. But it does mean people get scot-free away by saying a small list size of 3,000, which will still get the same £114 a patient, which doesn't allow the practice to break even, means in some rural communities, the GPs are struggling and, like you, desperately, desperately want to do the right thing for their patients, but are unable to do so because they don't have the resources or the support that's required. Do you think there's a place for the Royal College to step in with a view on what should be a minimum staffing architecture? It's harder in primary care only because of the diversification of the roles. But do you think there's a role there?
I think so. I mean, definitely part of our observation was at 8,000 patients with four doctors, as an example, who is the mental health lead? Who is the prescribing lead? Who is the CQC registered manager? Who is it is really difficult and challenging, I think, to run primary care organizations with the expectations not only of the patients, but of what the system expects of general practice in that setup. And so I do think really that when you get to a certain size scale, if that doesn't enable you to have even the management infrastructure, the leadership infrastructure, and then the clinical infrastructure, I think it's really difficult to deliver high quality primary care services. And I think the people that do it in that setting and do it and do deliver, and many do, they're doing it despite the system. They're often working the hardest out of any of the professionals that we will see around the table. They're often not able to do the kind of jobs, I guess, that I've had the privilege of doing because they're just having to service the needs of their patient population and the CQC and the management. So I do think going forward that actually even for the people trying to deliver services, that a minimum cohort of management infrastructure and clinical infrastructure should be there, because I think otherwise the model for general practice is not sustainable. And certainly, I guess, again, as a trainer, looking at the next generation, they don't want to work in that model, and as people then who do have carried that model for 20, 30 years start to leave, then it is leaving big gaps in provision.
Thank you, Neil, for sharing, and that's really crucial. The system recognizing the role it has to protect primary care, or rather, an innovation of primary care, but ensure it continues to have the safe numbers that deliver the right outcome that we all want as clinicians in this. So I think there's something else that stood out, and it just stands out in the questions that have been posted to Neil, which is around transformation is less about the transactional business of changing role. It's more about how do people approach it and how do people accept the change. And that's the challenge. So even in the stories for your parents and then subsequently yours, you spoke about the healthcare assistant role being vital. And more importantly, you spoke about the journey to becoming a healthcare assistant actually started with you tapping into your population so that the patients became part and parcel of how the surgery was. But the question, in today's wonderful world where some really well-intentioned, well-meaning roles like the physician associates have been denounced on social media, unfortunately for the people who are doing some amazing work in that must feel so dejected consequent to the way the social media has portrayed them in some occasions. How did you, how were you able to come to a place where there was acceptance by colleagues within your own practice that said it was okay for the healthcare assistant to do certain things, which in the previous era, rightly or wrongly, were done by doctors. And don't get me wrong, I don't think it's the right place. 33 years ago, I was trained as a doctor, and the expectations from a doctor today are different than they are. And we still have doctors doing the same thing. And a part of you feels, golly, there are others who do it and do it much better. How did you
Yeah,
achieve?
and I will tell you the story of one of our partners, Dr. Azar Chowdhury. So Dr. Azar Chowdhury joined this, I guess, quite a family setup, having worked in Scotland, and he joined the practice. And when he started, he saw the model that we were working with, and he said, I don't want to work with healthcare assistants. I don't want to put this is in 2008, so it wasn't that long ago. He said, I don't want to put my registration on the line. I don't want to do it. And then I think one day he was like, "Let me try it. Let me see." And so what he found, I guess, was having someone to help augment the consultation to do some of the administrative work alongside a GP turned it from, I guess, a GP against their morning list to a GP working with a colleague, and sort of seeing that patient population together. It also then allowed kind of just much better facilitation of a consultation. The chaperone was in the room. The healthcare assistant is trained to stock the room, so there's KY jelly. They know where the urine dipsticks are. All of those kind of softer things are the things that I think burn out the profession. Hunting around in cupboards for urine dipsticks, filling out Anglia Rice forms for about 3 minutes as you try and find the right thing to click, etc. Other thing, and so actually, as people then see that kind of, the not just the benefits to the patient in terms of communication, but also then the benefits to the consultant in terms of working with a partner to help you do the consultation. That's where it happened. And then I guess then as people joined us, we still made it optional. We were kind of like, well, it's up to you. You can use it if you don't. And but as it became the growing model of the surgery, that's then what took over. And now none of the doctors work without healthcare assistants. In fact, when there's not enough healthcare assistants, people get angry. Where's my healthcare assistant? Why are they not here? What do you mean they're sick? What do you mean they're on holiday? So and actually, so for myself, I work with Paulina, who's one of my healthcare assistants. I've worked with her for 7 or 8 years. She knows how I think. She often knows what I want to do, and we've got a relationship. We've got a relationship that together we are providing care. And so actually that kind of sense of working to each other for each other is a really positive relationship in the workplace. And so that's the kind, in the early part of the model, the other thing that we kind of pioneered or experimented with was that actually then doctors would share an office. So the healthcare assistants would have the fancy rooms, fancy clinical rooms, and the doctors would have a combined office. And so what that meant is that actually we were talking to each other between cases. We were filing our results, we were filing our letters, we were learning from each other. And often then we partnered a kind of more senior doctor with a junior doctor, not necessarily a trainee, but someone who just joined the partnership. And so that then helped people talk about referral pathways and things like that. That was the model that we had up to the COVID pandemic. We were sharing offices, we were doing it. It was all working really well. And then obviously COVID. How do you start sharing an office? But yeah.
Fabulous, fabulous. Neil, I think the other part that did stand out was you had a phenomenal number of staff working in the practice for a list size of 31,000. So um, we run a list size of about 80,000, and I think your staff per patient ratio is much higher than many other practices I have seen. Um, Clearly, you also spoke about the reliance of your increasing clinical care and your business um, opportunities by providing pharmacy, endoscopy, so other parts of the service. So I'm going to ask a question, given your considerable experience in this area, how possible is it for someone who is only relying on the GMS or PMS contract to be able to provide the same staffing ratio for care? Or do you think that would be a challenge?
I think it would be a challenge. I think the pounds per patient, especially in deprived and challenged, obviously our patient, our practices in the middle of inner city deprived Peterborough, our waiting per patient is really poor. And so I guess part of what makes us look for every single opportunity is I guess seeing it as an opportunity. So seeing the primary care network DES as an opportunity. So with that, the additional roles reimbursement scheme, we've always seen that as a massive opportunity. And actually, I guess the reason why we can have 120 staff is because obviously some of those will be then PCN staff that are allocated to our practice. And in a way, Peterborough has kind of over the last couple of years been spending more than its allocation. So as a system, we've looked at the ARS spend and it's moved money from, I guess, generally the more affluent areas to the more deprived areas. And then, as a practice, we have fought really hard for our patient population. We've activated ministers and we've all done all sorts of things the commissioners would be potentially quite grumpy with us about. But what that has brought to our practice is recognition that we look after an atypical population. So our population, 80% of whom do not speak English, and we cannot have a conversation directly in English. We have to, they speak Polish, Lithuanian, Russian, Latvian, some of the Asian languages, but, relatively little in our population. That has brought with it an uplift to our GMS of about 20%, right? But to achieve that took a lot of work, a lot of effort, a lot of understanding, a lot of producing data and figures to achieve that uplift. And so kind of part of what funds our HCA bit of our model is that recognition of the atypical population that we serve. And so that is partly how we do it.
Thank you for sharing that, Neil, because I think it also gives the other GPs and partners or other commissioners who are on the call today, because I can see a fair few people and some I recognize directly, including your partner. I see her, she's there too. So I think it does give them a feel that the opportunities in primary care are massive and the transformation actually helps patient care. Because I'm going to come very quickly to the important question, which I know your slide you'd put up briefly, but you were going to talk to, is the actual impact it's had. Because your model of care with pharmacy aligned and pharmacy first seems to be a model that you have started much before it's become national policy. So I'm going to ask a question. What's the outcomes you've seen in terms of A&E attendances, in terms of repeat? I hate the term frequent flyers. It just sounds like patients are wrong in coming there. But actually, in terms of making sure people can access the right care at the right place rather than turn up at the GP practice. Because I've been to GP practices where you can see any number of toothaches turning up because they just can't find a dental appointment. Now, the patient's not to blame. If they can't find an appointment, they are going to reach where they can reach for care. But how do you then make sure they are at the right place at the right time without having to wait unnecessarily? And I absolutely love the concept of focus on access. That's what people need.
Mohit, and that's why I want to build a dentist. Okay, so we are going to put a dentist into middle inner city Peterborough. There are no dental facilities. I think there is a really innovative way that dentists and general practice can work together. But specifically, I guess there's two bits of that. So one bit of it, I think, relates to the pharmacy first integration. So actually, for many years, community pharmacy, and general practice have been fighting over flu jabs. Okay, flu jabs are a red herring. Okay, now we can just decide who's doing flu jabs. Okay, you do it. You use a workforce for that, and we will use our workforce for doing other things. Okay, and generally in general practice, most general practices that are at scalable size don't depend on their flu income. Okay, because when you look at your flu income, it's not that profitable. The amount of time that you've got to put in to deliver the flus versus the money that you get in, has gone down. So utilizing your partners in primary care to help deliver a better service to your patients, I think is the key. Because once you've got access, someone can contact Thistlemore and say they want help, they've got a sore throat, and we can signpost them directly to the pharmacy, go to the pharmacy, have a consultation. If you need antibiotics, you can give it. The patient gets what they want. We preserve the capacity in general practice, and we also then allow our community pharmacists to do things more interesting than counting tablets. But to do that, the reason why pharmacy first is so difficult for pharmacies is that if you look at the workforce model of community pharmacies, generally pick up most in the country, they've got one or two pharmacists, one or one and a half. They've got they're down to their bare bones in workforce, and therefore they cannot deliver a meaningful service. So I think the primary care family talking to each other, working out which bits of the pathways we can work on and making that better, I think is really important. In terms of the work that you quote, that I guess had a slide on that I didn't talk about, like you. So for me, I often get nobbled to say, Neil, you are always talking about stuff. We're going to do a population health pilot. We want you to do it. Okay. And that's often I think it's to shut me up. I think it's because they want to keep me busy because they think that by keeping me busy, it's going to stop them banging on about my atypical population and all that kind of stuff. Right. So they want to do that. And then the system kind of talks to me to say, well, how about your uncontrolled hypertensives? And I said, well, that's not really, I've got Agnieszka. Agnieszka's spending her whole life looking at my uncontrolled hypertensives and trying to engage with them. I don't think I really want to do that. What I want to do is try and understand my patient population better. Okay. And what I want to understand is this concept of frequent flyers. Okay. We want to look at our top attendances at A&E and at the GP surgery who don't have medical conditions applied to their names. They haven't got labels like diabetes and renal failure and things like that. And we kind of want to understand why they're utilizing our service so much and the hospital so much. And the reason why I really want to understand that in a selfish way is that if I can stop them, attending my GP surgery so much, I've got some capacity that I can use for other things. But also, here's my null hypothesis. My null hypothesis is if they've had 19 consultations at Thistlemore, what does the 20th give them? What is it that what keeps bringing them back to us? And actually, where is that need? And a bit like your opening, Mohit, what I believe is that actually the reason they're coming through our door is because we're accessible. They're able to come through our door. They know how to access us. They can get in. I believe, having been a GP for 15 years, that the things that they say to me in a consulting room may not be the real reason which they're coming. I believe that actually the wider determinants of health, housing, employment, jobs, lack of social support, those are the reasons that really bring a patient through our door, especially when you look after deprived and challenged populations like we do. Okay, they've got real symptoms that are genuine, but the reason that keeps coming them back is because they don't have the privilege that many of the hopefully 400 people on this webinar have. That they don't have the support, they don't have the job security, and they don't have the enablement to get to make things better for themselves. And so what we did is we got together, we trained ourselves in motivational interviewing. Gina, who's on the call here, helped lead some of this work alongside the council. So the council trained us all into doing it. We're lucky to, as a training practice, we have about 7 or 8 trainees, 2 of which are given to us because we're a deprived practice, and they're in our practice to learn about deprivation and the effects of deprivation. And so those doctors were involved, not because of the medical side, because they were doctors, but also because of the opposite of that, to kind of teach them about real holicism and what it means and the wider determinants. And so they were part of this group as well. And between Gina and these 2 doctors, this has continued, so we kept it going, so it's 2 new doctors now, they basically spend their time understanding this patient population, understanding what was going on, understanding what was going on in their lives. They were asking questions about their housing, about their benefits, about their job, about their family support. Yeah, they also addressed the medical stuff. So, if they said, well, I've not heard from the hospital, let's look into that. Yeah, okay, this is what's going on with that. And what we then did, the reason we did it that way is we wanted to learn what was really going on in these people's lives. And beyond a 10-minute, 15-minute consultation where we're focused on a medical model of chest pain and coughs and colds and things like that, but what's actually going on in these people's lives, and using that to understand what was there and understand what was lacking. And Gina, who's a social prescriber, with her social prescribing knowledge, could then signpost them to various things. As part of that journey, we realized there are gaps. So some of the things that we could signpost to, but what we believe is that actually, again, at scale general practice can be an anchor organization. And definitely for my population, if I say go to the job center, that's not enough. They won't go. Many of them won't go. If I book them in to see someone in Thistlemore who works at the job center, they will attend. Yeah, not 100%, 80%. But the referral rate to the job center, 0% or 5%. So what we find is that actually, if we co-locate some of this stuff in the medical center, that makes a real difference. And so the frequent flyer project, as per the statistics on the side, reduced. So we were looking in a way from a selfish GP lens, but also seeing ED attendances. We were looking for 10 or more GP attendances and 5 or more ED attendances, also 2 or more ED attendances. When we got our top 400 people that did it, on average, they had 20 attendances in general practice and they had 5 attendances in ED without any real medical need to do it. Now, obviously, that doesn't count mental health, anxiety, all that other kind of stuff, but no medical labels that signified it. After just the intervention of talking to them for an hour about what was going on in their lives, signposting them to extra support, tracking that cohort through, their GP attendance is reduced by 75%.
Wow.
Their ED attendance is reduced by 29, so I say 30%, across that whole cohort of people that we saw. Okay. And that's seismic, so that was how the project started. And we were like, wow, this is amazing. Now, a bit like what I like to do, Mohit, then is experiment and think about things. So a local person who does Tai Chi said, can I use your surgery to deliver some Tai Chi classes? So, yeah, of course you can. Of course you can. But I want to put some of my frequent attenders into your clinic because actually, if we then link them up with some Tai Chi, physical exercise, mental health, what does that do? And so now we're sort of tracking through the input of that. Gina, then, nationally, it's very fashionable to think about job and supporting people with jobs. And definitely as a GP, what I saw, loads of people picked up by beautiful companies that I love, IKEA, Amazon, great companies, right? But I saw a pattern picking up people in their 20s, making them work really hard in their 20s, 30s, physical work. And then by the time they're 35 or 40, they're not fit to carry on that job. And so time after time, then they start on the sick note kind of bandwagon, they get a fit note and get into a cycle of it. And what we thought is, well, how do we interrupt that cycle? How do we start thinking as people start to break down? It's not their fault. Put me and Mohit in that job. I don't know how long either of us would last. I don't think that long. They're really challenging physical jobs. Okay. So how do we start kind of thinking about how we support them? Well, actually, one of the things that's really important is supporting their language skills. They don't speak English so well. So actually, let's host some language lessons for them. Let's book them into language classes at Thistlemore. Let's get them to improve their language. And early results from that pilot, roughly 100 people have gone in, 70% have been supported with language support, and 30% have left with a different job, after being through that program. So, come to your GP and leave with a different job. I think that's an amazing, I think that's amazing. I think GPs up and down the country should be, getting on that bandwagon and I guess the thought is then, if you're in a different job, if you're in a better job, if you've got better kind of, privileges and life support, you're probably going to use your GP service less.
Fabulous. Very inspiring, actually. Very, very inspiring, because the work we've done with Professor Mohammed actually does show the impact of the determinants of health have a much wider outcome than just addressing the health needs. And I think it also picks up the issue around integration, which you started touching on around local authority and working with them. So there are some questions, and clearly I'm going to pick up a wider question around how did you find, what were the challenges you found in working in an integrated fashion? Now, in your surgery, the pharmacy actually is part of the surgery. You got your cousin who's running it, and they are part of it. The pharmacists rotate. But then there are the mental health teams, the community mental health teams, and how do you work with them and then work with the local authority? Because actually, if that system outside the hospital truly strengthened, you can make such a difference to the utilization of secondary care. What was your learning from this, and what did you think were the challenges that people need to think about who see today's webinar and think, when I go back and I'm going to try something different, this is what I will?
I mean, I hope people will leave this webinar and open up a job centre within their practices and open up a dentist in the next year. That's what I hope I will inspire the GP fraternity to do. So it is hard, right? There are loads of. If you look at the story over the 30 years that we've been at Thistlemore, it's an amazing, phenomenal story. But at times, tears. There's been a lot of heartache in that journey towards providing the services that we can currently provide. There still is heartache, right? Everything does not go our way or my way, right? So you always have to work with partners. I find, though, if you take it down to its purest, what are we trying to achieve? The reason why I believe in integration is when you get down to it, whether you're in the council, in a pharmacy, or in a GP practice, your job is to add value to people. Okay. Some people believe the job is to run an Excel spreadsheet and decide how services should be run based on how much it costs. That's not it for me. what's in it for me is, where is the commonality in service? Where do we actually realize where we all can add value individually or together? And I guess as I tell the story of the pharmacy, what I don't tell you is that actually, sadly, after 10 years of my cousin running it, she walked away. She walked away with no notice. She just walked away, handed the keys. There you go. Good luck. No workforce. You know, there were, for the people that are around Tisselmore, there were queues outside the community pharmacy down the road. There were security guards brought in. That was a year ago. Okay. How did we get there? We got there from workforce. Yeah. Workforce is the key. What we realized is we needed enough people with the right mindset and the right skill set and the right attitude to take us through there. And I guess for us, what we're very lucky with, it's both an advantage and a disadvantage. The advantage is we're in a deprived, challenged environment. And so people want to put resource and effort and energies to make things better, because there's a massive agenda around trying to reduce health inequalities. With that, though, becomes the challenge, because the population that we look after are challenged, because of all those wider determinants. So I think it is, as I said, connecting with the right people in your area. And to me, it doesn't really matter about Lanyard, what they are. I would say the people with the joint vision, the people that are trying to do similar things in the community, some of whom work for the council, some of whom work for other providers, I think you can get things done. I think it's mostly about that, is that if you are trying to add value in a cohesive way, that's the recipe for integration for me.
And that's beautifully put. That is beautifully put, because I think it is not easy. The answers aren't simple. You need to be on it regularly, but the opportunity and the benefit, both to patient care and to the experience the clinicians have in the system from working in it, because they operate to the top of their license, creates a very unique opportunity for people to get. And we are coming to the close of this, so I'm going to ask you one very quick question. For our commissioners, how did they find, how long was the journey for them to recognize the challenge?
I would say, with a smile on my face, so I was chief executive. I was the chief clinical officer of Cambridge and Peterborough CCG for 4 years. Okay, so I get the commissioning world. Okay, I wouldn't say I'm an expert, but I definitely understand how it's wired. I understand the pressures that commissioners have, and certainly, I guess my reflection on my career was I didn't do enough. I didn't do enough with the opportunity that I had. I was in a very powerful position with £1 billion worth of NHS money. The current person in my role has £4 billion worth of NHS money, which is probably more than many countries have to run their countries, but that's the budget that they're responsible for. How do you make best use of the budget? And what I'd ask you to do is to turn away from your Excel spreadsheets. Don't think about patients as cost. Don't think as providers as not swallowing the growth in the inflationary pressures. Think about opportunities. I think for commissioners, think about what can you achieve. As a commissioner, your levers are limited and small, but if you see the world as cost pressures and inflation and everything's a pressure, that's not the way to frame the opportunity that you've got in your job. See it for the opportunity. How do you change how care is provided? How do you join people to work together? That would be my message to commissioners.
Neil, if there was a word today that could describe being insightful, rejuvenating, uplifting, helpful, and fabulous, all is one emotion, I would love to use it today to say, that's how I felt the webinar went. It was just phenomenal. And I think some of the things you thought, I will come back to the fact that thank you to your parents, because whatever they did, they certainly got the right outcome with the work they started off, and you led it beautifully. I think I love the terms you used about pushing boundaries, about embracing challenge, but focus on the population, because the needs of the population, like access, is what you should be pushing for. And love the bit about growing your own. There are lots of comments about that, even in the Q&A, about harnessing our own populations so that the population focus and the population health focus changes the way the surgeries operate. Love the stories you shared. I think it so resonated strongly that I often think we forget to harness the power of our clinicians and of our patients so that our clinicians can operate to the top of the license. Especially in primary care, when staff morale is at the lowest possible ebb, being able to support and creating a different cadre of professionals supports the license for those professionals who are working in a way that develops their potential much more than it could be. It was incredibly vitalizing to hear what you've done, and congratulations. Colleagues,
Thank
for
you so
those of
much.
pleasure. For those of you who are on the webinar, our next webinar is going to be our guest there would be Dr. Lucy Martin, and she is in the webinar today because I know she's logged on. And Lucy has been the medical director for the Dudley Healthcare System. So we're going to have a conversation around integration between acute and primary care because it was the first in the country. There's a lot of learning. There's a lot of stuff that went right and made massive difference. And there will be things like every change that didn't quite go right. So we'll get the pleasure of hearing that from Lucy directly on that. And a special thank you to two people who sit in the background, patiently make this work beautifully in a way that no one recognizes. Ola and Sarah, thank you both. You are phenomenal powers and make sure this works beautifully and keep me on check. They make sure I know my timing's right. A very, very big thank you to Dr. Modha, who has made some remarkable strides in primary care and shared with us today, which we are very grateful for. Of course, no webinar would ever have the gravitas that these webinars have without the active participation from so many viewers and listeners and participants who participate. I mean, there are 400 of you who have registered today, and we are on multiple platforms, for which I am very, very grateful. Sarah has posted a link on many of the platforms for you to give your feedback so we can actively collect this feedback and make sure our webinars continue to focus on things that matter to you. As usual, fabulous evening. Thank you so much for staying with us. Have a great evening. Bye, everyone. Sarah, will you close the webinar recording?